The following podcast is part of a certified educational activity titled The New Therapeutic Era in Renal Cell Carcinoma, Essentials for Team-Based Patient Care. Access the entire activity and complete the post-test at peerview.com/RYZ860. Downloadable slides and practice aids are also available.
Hello, and welcome to the New Therapeutic Era in Renal Cell Carcinoma, Essentials for Team-Based Patient Care. I'm Laura Wood from the Cleveland Clinic Tussock Cancer Center in Cleveland, Ohio, and I'm pleased to introduce Dr. Monty Paul and nurse practitioner Kathy Burns from the City of Hope Comprehensive Cancer Center in Duarte, California, where they work together as a clinical team. So we'll go ahead and get the program started, and I think it's important to start with a brief overview of how immunotherapy works and the interaction between the immune system and cancer cells. When normal functioning occurs, T cells and the immune system recognize cancer cells. But what we have learned is that cancer cells have a way of disguising them and therefore not being detected, recognized, or destroyed by the immune system. Our immune checkpoint inhibitors are an anti-cancer strategy. And what these do is take the brake off where the cancer cell inhibited the immune system. It put the brake on the immune system. So when we talk about our checkpoint inhibitors, their role in the immune system is to interfere with the PD-1, PD-L1 interaction, allowing the T cell to then become activated again and continue the work of the immune system in destroying cancer cells. So when we think about our therapeutic strategies, the three of us felt that it would be a good way to take a case study, and we're going to walk you through this case study, treatment options and treatment decision-making. So we have a 60-year-old male who presents in the emergency department with new onset hematuria and some vague abdominal fullness. His ECOG is 0, working full-time. Lab tests demonstrated hemoglobin of 14.3, creatinine of 1.21, and the other labs are all within normal limits. So part of the workup in the emergency room department is that of a CAT scan. So the CAT scan of the abdomen and pelvis being done for hematuria and vague abdominal symptoms demonstrates a 7-centimeter renal mass, which you see here on the CAT scan on the left. The patient is then discharged from the ED, follow up with a urologist who does additional staging, including a CT scan of the chest demonstrating pulmonary lymph node metastasis. The further workup demonstrates no abnormalities noted on a whole body bone scan. So we've got a patient presenting with stage 4 synchronous metastatic disease with a left renal mass. So the first question that is discussed between the urologist, the medical oncologist, the patient, and their family is he a surgical candidate? Do we start with a nephrectomy and follow that upon recovery from surgery with systemic therapy? Or is this an individual that is really not appropriate for nephrectomy and therefore should start frontline systemic therapy and, based on response, possibly continue the conversation about a nephrectomy or a cytoreductive surgery? So, Dr. Paul, what would be your most important patient or disease characteristic that would lead you to recommend starting with systemic therapy?
Yeah, it's a really fantastic question, Laura, and I definitely think that this is one of the most common clinical scenarios that Kathy and I encounter at our tumor boards. That patient with de novo metastatic disease, the primary tumor is still in place. One of the important details I think that you included in this vignette is that this patient is having hematuria. You know, in my book, there are 3 signs that we really sort of look for in terms of suggesting that that patient should probably head immediately to surgery. And those are significant pain derived from the tumor, any perineoplastic syndromes. So these are syndromes that are associated with kidney cancer, like hypercalcemia, for instance. And the third would frankly be bleeding, and that's what this patient has. So my recommendation in this scenario would be to have that patient go directly to the operating room, and we can always consider initiating systemic therapy either simultaneous with that or immediately thereafter.
Great, Monty. Thank you so much. So, Kathy, what other factors would affect your decision regarding surgery or systemic therapy, or things that you might bring up to Dr. Paul in the workroom?
Sure. The things that I would be most concerned about is to get some time with that patient after they've heard the plan. I think things that are important that can play a role in treatment decision making are going to be patient support system, transportation, distance to clinic, financial issues, as well as I would add at this point, now that you've heard what the treatment plan is, what are you most concerned about, or what's the most important thing that you'd like Dr. Pal to know about you?
Yeah, you bring up a good point, Kathy, regarding shared decision making. It really is very much a collaborative decision between the providers, the patient, and the families, and making sure that the plan of care meets everyone's expectations. So really good points. So Monty, you want to take us through the next slides, which really talk about where we've been and where we're going with our treatment options for kidney cancer?
Absolutely. It's such an exciting time. You know, if we were doing this talk 3 decades ago, it might be kind of dull because all we had at that point was interleukin-2 and interferon. But I mean, this slide just does a beautiful job of articulating the progress that we've made in the field. I actually joined the field around 2005, which is when sorafenib was approved. And it's just been remarkable. And I've shared a lot of these experiences at meetings with you, Laura, and you, Kathy, to see these developments along the way. So it starts with the VEGF inhibitors, like sunitinib and sorafenib. We then introduced mTOR inhibitors like temsirolimus in 2007. Then we moved on to probably the most exciting development in recent years, the incorporation of immunotherapy, once again with nivolumab in 2015. And then we finally move into multi-kinase inhibitors and combinations of these multi-kinase inhibitors with immunotherapy in the most recent 3 to 4 year span. So very, very exciting time. There are a number of tools that we use from day to day in terms of estimating prognosis in patients. I think, for instance, in that case scenario that you described, Laura, it's really helpful to take an individual like that and put them on this continuum. And this oftentimes helps us in the clinic allocate treatments, but it also really helps the patient understand a bit more about their associated prognosis. This is the so-called IMDC, or International Metastatic Renal Cell Carcinoma Database Consortium scoring system. It incorporates a lot of really easy to remember characteristics: the patient's performance status, the patient's time from diagnosis to systemic treatment, and then several laboratories that are easily at your disposal: the hemoglobin, the calcium, the neutrophils, the platelets. Laura had articulated that in this case, the patient was fairly functional prior coming into the hospital, and his laboratories were normal. He wasn't even anemic despite the hematuria. And this patient, however, had de novo metastatic disease, so that earns him 1 point. So you can look at this case and say, okay, he's intermediate risk by virtue of having 1 to 2 factors. And in the era of tyrosine kinase inhibitors alone, you might quote to him a survival of around 22 months or close to 2 years. Now, the bar is moving. And that's really on account of a number of combinations that have been approved. And we're going to have some time to get into the weeds with these. But as you can see, there's a number of different combinations that have really been suggested to be preferred regimens for frontline therapy for patients with either favorable risk or poor and intermediate risk renal cell carcinoma. You can see that ipilimumab and nivolumab uniquely is positioned for patients with intermediate and poor risk, and that hinges on some of the elements of the trial design, and we're going to get into that in just a bit. But I mean, gosh, it's just remarkable to see how many options we have for patients nowadays with this disease. Laura, I'll turn it back over to you.
Yeah, thanks so much, Monty. It is absolutely amazing the changes that we've seen over the last decade with the options for patients and the improvements in response, duration response, and survival. So looking forward to your presenting some of that information. So when we circle back to our case study, the decision was made to proceed with a left radical nephrectomy. So this patient went to surgery first. The pathology demonstrated a 7.5 centimeter renal mass, T3A-N1-MX disease. The margins were uninvolved, and that's an important thing that we as clinicians look at. Tumor necrosis was present at 1%, and sarcomatoid and rhabdoid features were also identified. And those are some of the histology suggesting where the disease is and the aggressiveness of the disease. And we didn't always have that. And so pathologists are really looking more at some of the intricacies of the pathology specimen and helping us identify characteristics such as sarcomatoid and rhabdoid features. So when we look at our options, as you mentioned, Monty, there's a lot of them now. And we've got CTLA-4 inhibitor that has been approved in metastatic kidney cancer, our PD-1 and PD-L1 inhibitors, and our VEGF-targeted TKIs given as monotherapy or in combination. And we'll talk about those more with Kathy, Monty, and I later on in the program. So, Monty, let me pose this to you at the moment. Are there any specific disease characteristics or comorbidities that might lend you to recommend one of those options over another?
Yeah, maybe I'll start by just discussing it in the context of the case that you presented. I would say that I'm fairly dogmatic in clinical practice. I think Kathy will probably vouch for this. I tend to kind of fixate on one regimen and sort of stick with it. And, after a really thorough assessment of the data, and I'll walk you through my logic later in the talk today, I tend to use cabozantinib with nivolumab across the board in the vast majority of clinical scenarios. But making this a little bit more nuanced to this particular patient, he had hematuria. He needed to go to the operating room right away. That's one of those scenarios where I might actually start with nivolumab and ipilimumab first. The rationale for that is that when you're dealing with cabozantinib, axitinib, any of the tyrosine kinase inhibitors, you have to factor in a period of time before surgery for the drugs to wash out. And perhaps more importantly, and this is a longer duration of time, you have to allow 4 to 6 weeks for that patient to recuperate following surgery before letting those tyrosine kinase inhibitors kick back in. Otherwise, you can have issues with wound healing. So that's why in a scenario like what you described, and it's such a great case example, I would probably start with Nivo-Ipi. And I think the beauty of it, Laura, is that, now I don't feel so restricted as I did in the era of tyrosine kinase inhibitors alone. I feel like I can see that patient in clinic, I see that they have hematuria, and I can actually get that Nivo-Ipi going before they go to the operating room to have their cytoreductive nephrectomy. So I think it's a major advantage.
That's an interesting point. And I know there are a number of clinical trials going on now that look at these therapies in the neoadjuvant setting. And in actuality, that's still on-label therapy because he presented with metastatic disease. So you bring up some really good points about disease characteristics. Kathy, what kind of things would you think about patient characteristics for treatment choices?
I think my one point at this time is if we're going to consider 2 IV infusions, it gives us a little bit of breathing room to assess patients' prescription coverage. This can be an issue as we move on to different lines of treatment, and I think it gives us a chance to assess things, make sure they have coverage.
Great. All right. So Monty, do you want to now cover the rationale between immunotherapy combinations and IO-TKI combinations?
Absolutely. So, I thought you did a really beautiful job, Laura, earlier of introducing the principle of immune-based therapy in broad terms. And I won't say much more about it here, but what you can see in the diagram is that this interface between the T cell and the cancer antigen presenting cells, you've defined it, is very complex. There's a number of different breaks that you can sort of let up on as a means of trying to intensify this interaction. One of them is the engagement between PD-1 and PD-L1. The other sits at the interface of CTLA-4. So combining the two seems to elicit some degree of synergy. Not only that, but over the years, I've followed a lot of the work that, for instance, one of your colleagues at the Cleveland Clinic, Jim Finke, has done, and many others in this regard. They've really done such a nice job of demonstrating that the activity of VEGF inhibitors really goes far beyond simply blocking blood vessel growth and formation, which is what we've classically associated them with. And what this really complex diagram outlines very fundamentally is that when you use targeted therapies, it can really change the immune milieu and really create a very favorable anti-tumor immune response. So there is some rationale to think that VEGF inhibitors and immune-based therapies can really work together. Now, this is really getting straight to the punchline here. This is the overarching data across multiple frontline clinical trials. This is the data that you saw for many of the choices that we considered in our hypothetical patient. Nivo-Ipi, Axi-Pembro, Cabo-Nivo. This wasn't offered as an option because it's not quite yet approved, lenvatinib with pembrolizumab. But what you can see here across the board is that in broad terms, we're seeing a relatively similar hazard ratio for overall survival. Each one of these regimens is producing what I would describe to a patient as being about a 30% benefit in terms of overall survival. In terms of progression-free survival, just as you might expect, you don't see a lot of benefit when it comes to the comparison of sunitinib against Nivo-Ipi. We haven't traditionally associated the tyrosine kinase inhibitors with anything less than an advantage over immunotherapy. But if you look at the other trials here, significant advantage with a VEGF plus IO versus sunitinib. Response rates also much higher when you combine a VEGF inhibitor plus immune-based therapy, and we'll talk about complete response rates in the context of some of these studies. So, I wanted to get into the weeds a little bit with some of these clinical trials. I think Checkmate 214 is an important study for us to go through in a little bit of detail because it really highlights how important it is to risk stratify patients. This is the design of Checkmate 214. I think it's a study that many of us are incorporating in clinical practice to use Nivo and Ipi. This importantly uses a dose of Nivo and Ipi that's different than melanoma. So you want to keep in mind the dose of Nivo here is 3 mg per kg. Ipi is given at 1 mg per kg. It's actually the flip of that in some melanoma regimens. But this regimen was compared against sunitinib in patients with metastatic, previously untreated renal cell carcinoma. I really like this slide because it offers a real juxtaposition. If you look at the overall treatment population, and that's on the left-hand side over there, you can clearly see that Nivo-Ipi, which is in blue, offers benefit relative to sunitinib, which is in gold. If you look to the middle, you see where that benefit is really coming from. It's coming from patients with intermediate and poor risk disease. Bear in mind that patient that we looked at in the case scenario was an intermediate risk patient by my calculation. So he would fall within this group and he would derive a significant benefit from Nivo-Ipi over sunitinib. It becomes a little bit dicier if you identify that patient as favorable risk. And this is the real critical criterion and why I always try to get that IMDC risk score in patients. If you see that that patient is favorable risk, you can almost see that sunitinib offers an advantage over nivolumab with ipilimumab. At least there's no significant difference there, in my opinion. The gold line here seems to track over the blue line through the majority of this curve. You can see that even better when we're talking about progression-free survival. If you look at the intermediate and poor risk population in the middle, clear benefit with Nivo-Ipi over sunitinib, no arguing with that. But if you look at the favorable risk population on the right, sunitinib once again really does better. So I would argue that in that favorable risk population, really try to consider using either a VEGF inhibitor as monotherapy, which I'll occasionally do in practice, or consider using a VEGF plus IO combination. Nivo-Ipi is probably not the way to go. Now, you've seen a multitude of these studies represented in that table that I showed you. These studies include pivotal trials assessing pembrolizumab and lenvatinib, cabozantinib and nivolumab, axitinib and avelumab, Axi and Pembro. And I really like this slide because it shows the uniformness across all these studies. All these combinations of a VEGF TKI plus immunotherapy were compared to sunitinib at the same classic dosing regimen, 50 milligrams, 4 weeks on, 2 weeks off. What we'll quickly do is go through the results from these studies and some of the more recent data. You can see here that Axi-Pembro versus sunitinib in the overall population, this isn't just restricted to patients with intermediate and poor risk disease, leads to a benefit in overall survival. There's an advantage in progression-free survival as well. And one of the interesting things here is that when patients made it to the 2-year mark, they were actually allowed to discontinue therapy with pembrolizumab. And amongst that cohort, if you look at survival on the left, you can see that most of them fared pretty well. You don't see this Kaplan-Meier curve diminish very much. So to me, that indicates that if you were to stop the pembro at the 2-year mark, there's a chance that patient could still do really good. And, I think one of the things we can certainly discuss as a group here are some of those long-term toxicities that patients start incurring with immunotherapy. This is the Javelin Renal 101 study. I will say that this is an important data set, but not one that really rises to the level of clinical practice, in my opinion. It looks as though there's a significant advantage in progression-free survival with axitinib and avelumab versus sunitinib. But amongst all the other phase 3 studies that we've seen to date, this one did not produce an overall survival advantage. So I think that this has been pushed by the wayside, and I would actually caution you in the audience away from using avelumab as a partner for axitinib in this particular context. If you're going to use an axitinib-based combination, it should probably be with pembrolizumab. Now, here's the data set that I'm actually quite fond of, as I'd mentioned. This is the Checkmate 9ER trial, and it compares the combination of cabozantinib plus nivolumab against sunitinib therapy. And you can see here a significant benefit in terms of both progression-free survival, which is on the left, and overall survival on the right. And, we're seeing this mark of progression-free survival improve to a greater extent with each iteration of the data. Here we see a progression-free survival of 17 months, approaching a year and a half with a combination of cabozantinib with nivolumab. Now, the reason that I like this data set so much is twofold. And I think Kathy's done a beautiful job of talking about patients' concerns and what they really want in the context of systemic treatment. I find that many really prioritize quality of life, how they're going to feel. It's very important to note that in the context of Checkmate 9ER, there's a 40 milligram dose of the drug that's utilized, not the 60 milligram dose that we're all used to using in the second and third line setting. And that's of critical importance because I feel that 40 milligram dose is much, much better tolerated. So that certainly lends itself to benefit. And I'll also note that the combination of cabozantinib with nivolumab has been associated with a very significant benefit in terms of quality of life. We haven't seen that in any of the phase 3 data sets to date, so I think this speaks volumes to why I would use this regimen in clinical practice. Now, this is data for the combination of lenvatinib with pembrolizumab in patients with renal cell carcinoma. You look at this data and you think, wow, what a discrepancy in terms of progression-free survival there, 9 months versus 24 months. And certainly hitting the 2-year mark with PFS is a major, major milestone. So, as we sort of talk through the pros and cons of the combinations of IO-TKI therapy versus IO-IO, there's lots of salient points here. I won't go through all of these. I'm sure many of these are going to come up in the course of our discussion. But many of the pros of the VEGF-IO combinations include that there's benefit across risk groups. You can use that in the context of favorable risk disease, whereas with nivolumab and ipilimumab, which is an IO-IO regimen, you should stay away from using it in favorable risk. I will say that perhaps IO-IO is associated with a slightly higher rate of complete responses. But on the whole, these are many of the discussion points that fuel the conversations that Kathy and I are having in the clinic with our patients. Laura?
Great. So another point to make is that these clinical trials were all done in the clear cell patient population, as was our case study. Now, what would your recommendation be if the patient had papillary renal cell carcinoma?
Laura, thanks a lot. And I feel like, this is a perfect opportunity to segue in some data that me and Kathy and the City of Hope crew were involved in leading. We participated in this trial, SWOG 1500, and this has been a real sort of labor of love. It took about 10 years to complete this study across multiple institutions throughout the US and Canada. But this was an ambitious study that's set to really look at papillary kidney cancer and acknowledge its biology. We know that papillary kidney cancer is not always driven by VEGF, which is the key driver of clear cell kidney cancer. We think it may be driven by a protein called MET. And so I think quite logically, we decided to compare sunitinib, which was the existing standard for upfront treatment, against 3 MET inhibitors, crizotinib, savolitinib, and the drug that we focused on a lot in the last portion of my presentation, cabozantinib. So this was a 4-arm study in this rare population. Papillary kidney cancer is only about 15% of kidney cancer cases. And what we saw here was pretty clear. In this study, which was powered to look at progression-free survival, and I know this resolves a little bit small on your slide here, but on the left-hand side, it looks as though cabozantinib really edges out the 2 other MET inhibitors and sunitinib in terms of progression-free survival. So in my practice, I think that cabozantinib has really sort of emerged as the standard of care in this setting, and it remains to be determined whether or not combinations are going to beat that.
So good overview. Thank you so much, Monty, for the overview of our therapeutic strategies. So for our case study, the treatment decision was to proceed with an IO-TKI combination. So Kathy, do you start both drugs at the same time, or do you start them based on whichever drug gets prior authorization first, adding the second drug in when it gets approved?
Mm-hmm. It would be great if we lived in a perfect world and everything appeared at the same time on the same day. So yes, that would be ideal. I would recommend if the oral agent comes first prior to that infusion appointment, no problem. I would start it for sure. I think what's important to think about at this moment, though, is that period of time waiting for authorization, scheduling, is fraught with patient and family stress, right? Anxiety about scheduling, finances, uncertainty about what to expect. At this point, I would ask all of you to go back to your practice areas and consider what the roadblocks are for our patients at this moment, how we communicate, how patients can access us with their questions and their concerns.
Yeah, that's really important, Kathy. Thank you. I've actually got a question now from the audience, and the question asks about how reimbursement plays a role in the time between treatment decision and initiation of treatment. You know, we don't like to order the infusion, order the drugs, get them started right away. But what do you and Monty see in your clinical practice as far as the reimbursement? And you somewhat mentioned it with the roadblocks.
Yeah, we're often working with 2 different teams. So we're talking about financial authorization with infusions, and we're also talking about authorization with prescription medications. Pick a very reliable specialty pharmacy and continue that conversation with them to make sure that patient is receiving assistance if it's applicable with their copays. We're talking with Cabo in particular. They have a really nice program that they'll give the patient 2 weeks free while this is in process. So,
yeah, that's a good point. We do have good pharmaceutical company support for our patients with the ability to initiate some of those early on with the assumption that we're going to get a financially plausible approach for the patient for continued treatment. So yeah, you're right. The patient assistance programs and getting our specialty pharmacy to assist us with that process is great. Now, Kathy, again, what are some of the important pieces that you want to make sure the patient and their caregiver get? Do you do a patient education visit separately from the clinic visit at your institution, or do you incorporate patient education into the visit where you and Monty make the decision, the recommendation for treatment?
Well, we actually work in a very large facility with the opportunity to do a separate chemotherapy teaching, either in person or virtually. I think it's optional. Not all patients take advantage of it, but I think it's critical. The other pieces that I think are important at this time in particular are going to be education and support, but I would take that even further, and I would include things like, this is the time that patients and families should be preparing and tuning up for these infusions. So are there any nutritional issues that we need to correct or address? Fitness, exercise, sleep, anxiety, communication. So all these things, we've got a little bit of time, not too much, but just enough time to get patients and families connected to the people that they need as they get started.
Something we do in our practice is we look at the patient's recent clinic visits, home blood pressures if they're already on antihypertensives, and give them specific parameters that would initiate a phone call to the clinical practice team. Is that something you guys do as well in a way?
That's a perfect idea.
Okay. Yeah, I think the oral therapies provide a challenge to make sure that patients are able to be compliant and persistent, both with the oral therapies, but also with the side effect strategies. And so you want to talk a little bit about the adverse events that we see with the therapies, Kathy.
So let's talk very briefly about the basic differences between a checkpoint inhibitor and a tyrosine kinase inhibitor. Unlike TKIs, checkpoint inhibitors are intravenous, administered on a schedule between 2 and 4 weeks. The use of calendars can be incredibly important. I think developing a basic calendar that patients can put numbers in so they know how that applies to them will help in the long run for sure. Checkpoint inhibitors are associated with that unique spectrum of adverse events that are likely related to immune stimulation. So there are a spectrum of adverse events that seem to have that are common to both TKIs and IO. So the slide that you're looking at right now is a great picture of 3 of the most common side effects that people can expect, being diarrhea, fatigue, and hand-foot skin reaction. These are things that are considered overlapping toxicities. So for those of us who've been in oncology for a long time, we know that when you combine chemotherapies or other agents, you try to avoid overlapping toxicities. This is a little bit difficult in the renal arena. So we do have some overlapping toxicities that come at our patients from different approaches, but can be troublesome. So these are 3 areas that I would really focus on as I'm doing chemotherapy teaching, or I should say immunotherapy teaching. As we know, as oncology nurses, fatigue is all across the board, right? There are a lot of contributing factors to fatigue, and nutrition and exercise and sleep and anxiety. But in general, we follow our great evidence-based guidelines, which include things like stay as active as possible. If you can, maintain a normal work and social schedule. Take breaks as needed. Most patients are going to feel the most energy in the morning, so let's kind of recognize that and fill that time with the activities that take up the most energy. Really let us know there are some kind of outliers that are potentially emergent that can cause fatigue, so make sure that line of communication is open. And there is some evidence for people that are experiencing both mental and physical fatigue from their treatment to add Ritalin. So let's talk in general about gastrointestinal IRAEs, including diarrhea and colitis. So diarrhea would be something that you would experience coming from a TKI, and the inflammatory colitis would be something that a patient could experience through checkpoint inhibitor. Onset is an incredibly wide variety of time. You can see onset is 3 days to 10 weeks, or even after this drug has been completed. In general, diarrhea is more common with the dual immune checkpoint inhibitors, but I would say that it's generally something that you're going to talk about with your patients with either the combination of IO-IO or TKI-IO. You do have risks, of course, with perforation and sepsis, so we always need to keep that in the back of our heads. Grading toxicity, I would highly recommend to all oncology nurses who work in clinics and monitor either triage phone calls or patients and their families in person. If a person calls in and says they're having diarrhea, that can mean an awful lot, and it's going to be a bit of a long conversation to really elucidate what symptom is that the patient's reporting, and kind of finding out what that background is. So it's important to know if their baseline stooling is 1 per day, and a patient calls and says they're going 3 times a day, that would be a grade 0. So it's important to know grade 1 is 4 or less stools above baseline, grade 2, grade 3, grade 4. Very important and very helpful when we're communicating with our teammates as to what's important. There are some guidelines, so I would definitely recommend NCI, NCCN guidelines for immunotherapy management. They can give you very clear guidelines as to, with this grade, what you do with each of the drugs. But I feel like as within my role, the first thing that I need to do is assess what's causing it and are there any external factors that might be causing it. I think the magical question in my mind that I ask is, what do you think is causing it? And sometimes the patient will tell me, it's the food I ate yesterday or the food that was still in my refrigerator, et cetera. So those questions are really important. Understand the frequency, the volume, is there bleeding? And let's go on to the next slide. So the other thing we haven't talked about yet in this program is the dermatologic IRAEs. So think about all the skin reactions that you've seen from drug reactions, from allergic reactions. I think for nurses and advanced practice, get comfortable with describing skin reactions. So all those words, macules, papules, all those should be in your toolbox or in your vocabulary. If not, look them up, but use those words in describing skin reactions. It'll help you in the long run for sure. The grading system for skin reactions is based on body surface area, so it's very important to do a full assessment of skin. So for example, a mild grade 1 skin reaction is going to be less than 10% of BSA. Definitely use our friendly professionals in dermatology. They are worth their weight in gold. So in general, it's important to have an idea of what we're going to stop, if necessary, based on a patient's reaction. If IO reactions are absolutely from that drug, the way to turn that off is with steroids. If the reaction comes from a TKI, it's generally withhold the drug and things resolve. So that will give you a clue as to management in the future. If we advance to grade 3 and 4 IRAEs, we want to consider discontinuing hospitalization, multidisciplinary evaluation. And then once high-dose corticosteroids are implemented, we also own the management and the taper of that afterwards, which is incredibly important. So one of the pearls that I use and have learned from Monty here is when a person's on IO TKI, they call in, let's give the example of a week prior to their appointment, and they have symptom A. How do you know what to attribute this side effect to? Which drug, right? As I said just previously, with TKIs, withholding the drug or giving them a break may give you a clue as to its attribution. So for this patient that we're using in the program, if they are taking cabozantinib, nivolumab, I would, if they called, let's say with diarrhea, intolerable grade 1 or 2, I would have them stop the cabozantinib until they come into clinic. That'll give you some data as to whether things are resolving or not. And then I would use that IO algorithm, and you may have to hold that as well. The other thing that's really important, I think, is knowing the half-life of the oral agent. Axitinib is a very short half-life, like 4 to 6 hours, so you don't need to hold it for very long. Cabozantinib, on the other hand, is 90 to 120 hours, so you really want to give that patient a decent hold. Include your infusion nurses, because often if someone's sitting in the chair, they're privy to a lot of information that we might not be in clinic. So open communication with your teammates for sure. And patients, clinical trials are always an option. As far as the patient's toolkit, I know when IO was first coming onto the scene and we were making a really big deal of wallet cards, right? We were so worried that people in the community wouldn't recognize or wouldn't understand what drugs we were using. And that is true. I think it's less true now, but something like this ONS wallet card, which includes their cancer diagnosis, what agents they receive, check mark for checkpoint inhibitors, multiple checkpoint inhibitors, that's so important, what the names are, when they started them, and then our contact. So if we're prescribing, we always need to be available for questions, and this will have a huge impact for sure. So in our nursing toolkit, get that app on your phone for the NCI toxicity criteria. Prepare with medications you would need to manage those toxicities. And I think what's most important is invite and request that patient call you. This is critical, but I also think on the flip side, we need to be the ones, if we know a toxicity has a chance of happening at a certain time, we need to be reaching out to that patient and checking in. So it's a two-way communication for sure.
Great pearls, and thanks, Kathy, for sharing on the adverse event management, because that really is critical to helping patients get the best out of whatever treatment they're started on at whatever point in their kidney cancer journey. So we circle back to our case study, and the patient calls in during the cycle 6 interim, day 15, so he's halfway through cycle 6. He's got some fatigue and some skin changes on the soles of his feet. And as you alluded to with the CTCAE criteria, the discomfort on his soles is interfering with walking. And he also casually mentions he has mouth ulcers. So, Kathy, how do you determine in this situation, is this a wait and watch? You're going to see him in the office, or is this somebody you should refer to the emergency department?
The answer comes from a lot more detail, so that's absolutely important. And I think knowing your patient and family and knowing how comfortable you are in their reporting, I would call that person back and get a better understanding of how painful the hands and feet are. Can they walk? Mouth ulcers, how painful? Are they preventing a person from eating? And so it's the degree of these reports that leads me to say, take a break, watch and wait. Here's some helpful interventions that might get you through. Or if someone has that much pain and they're not walking and they're taking pain medication, they're not eating and drinking, this is a person who needs to be seen urgently.
No, I think that's very, very important. Now, in this case, would you feel there were any appropriate labs to be drawn?
Well, with this person, I would worry about dehydration. So I guess it would depend a little bit on what the answers to those questions that I asked previously. Keep an eye on electrolytes.
Yeah, absolutely. A good thorough assessment is really what you're alluding to. So thanks. Actually, we've got another question for the audience. What are your criteria, Kathy, for treatment interruption? And then the second half of the question is, when would you decrease the dose without a treatment interruption? And let's continue with our IO-TKI combo.
Okay. I think before I get to this point, I would have had a conversation with the patient and family to explain that if you need a dose adjustment based on the side effects you're experiencing, it's not, it is an expectation that these doses need to be adjusted. And when you look at data in clinical trials, most of the patients on these trials have had dose adjustments, and still we see those results that we do. So we need to really manage those expectations and normalize dosing changes based on experience. So I think my criteria for treatment interruption, of course, is by toxicity grading score, but I think more important, it's by the patient's experience. If the patient describes quality of life or a certain type of quality of life, like the patient wants to be able to work or take care of their children, and these medicines are impacting their ability to do that, this is the time to talk about dose, hold, and reduction. So it's a combination conversation of toxicity and experience.
Yeah, so I know in our clinical practice, typically if you're going to need to decrease the dose of the oral medication, it's because the patient has hit the wall with the side effects, as you said, with the CTC criteria, and they need a treatment interruption to allow recovery so they can then tolerate the low dose. Would you agree, Kathy?
Agree completely.
Okay, excellent. So why don't we talk then, Kathy, about triage tools and what nurses need to know?
Yeah, I think whether you work in a small office, small clinic, or a large hospital, knowing those folks that either take the triage calls, or those folks might be you that work in a clinic that answer the phone. The skill of a good triage nurse can save lives. And I think it's also important to establish some sort of standard algorithm. So there's lots of them out there. I used to use, when I worked in a smaller office, the ONS telephone triage for oncology nurses, sort of as a guideline. Now I work in a larger place, and our EPIC system and our team of triage nurses has a very specific algorithm. Hugely helpful, a little hard to get used to because those questions are not always conversational, but using the algorithm, grading and scoring, I think using the idea of the opportunity for us to use telehealth can be super important when we're talking to patients or caregivers or both. Utilize telehealth, get the family members on the screen.
So thinking about this patient, and at some point he's likely to have disease progression, given the treatment, Monty, the treatment options that we now have in the refractory setting, for somebody who's relapsed or become refractory to two more systemic therapies, what do we now have available that we haven't had in the past? How do you make those treatment decisions?
Yeah, it's such a great question, Laura, and I really appreciated the discussion that you and Kathy just had around, picking the right therapy for the right patient. I mean, it's very nuanced. You got to listen to and detail their wants and needs at various time points in their treatment. I think before this was a data void area. We're really lucky now to have a couple of really level 1 evidence trials that offer some credibility to what we can use after a patient fails on a checkpoint inhibitor in the frontline setting. This is the Tivo 3 clinical trial, which me, Brian Renal, and a handful of others led. And this was an experience to really characterize the activity of tivozanib versus sorafenib in patients receiving third or fourth line therapy. A really golden opportunity for us to really explore whether or not there was activity with drugs beyond checkpoint inhibitors. And in this study, which you can see on the left, is a significant advantage in terms of progression-free survival. On the right-hand side, I'll point out that tivozanib barely edged out sorafenib in terms of overall survival, not much of a difference there. But in this third and fourth line setting, I think this represents an important treatment option, and now tivozanib is FDA approved. I'll point out that this agent bears a lot of likeness in terms of mechanism to axitinib. And so one really nice thing that Brian did at this year's ASCO is he actually was able to look specifically at those individuals that got axitinib prior to tivozanib. And it doesn't seem to be a Me Too drug, because you can see here that patients that had received prior axitinib therapy still did better with tivozanib versus sorafenib, a progression-free survival of 5.5 months versus 4 months, You can see response rate was nearly double, 13% with tivozanib versus 8% with sorafenib. Now, kind of getting back to the dialogue that you and Kathy were having, Laura, I'd propose that the one edge that tivozanib has is in terms of quality of life. I really do find tivozanib to be a pretty well-tolerated drug. And in my hands, I've had patients on the agent for 3+ years, and it's just been really impressive to see the sustainability of the agent. So, nowadays when I'm talking to patients, if their performance status is perhaps a bit impaired as they go into the 3rd or 4th line setting, tivozanib is on my radar. We also participated and led this study that looked at 2 dose levels of lenvatinib. We might have similar efficacy, but get away with perhaps a little less in the way of toxicity. Ultimately, what this study showed is that we probably should be sticking with 18 milligrams. You can see that the 18 milligram dose edged out the 14 milligram dose in terms of progression-free survival. And in terms of overall survival, again, 18 milligrams had a very slight edge there. So unfortunately, we weren't really able to move the needle much. And I think that lenvatinib just remains exactly what I said, a good option, but a tough to use option amongst patients in terms of toxicity. Now, there's a lot of interesting stuff on the horizon. I think a lot of folks are very excited about belzutifan, which hits this target called HIF-2 alpha. When we think about VEGF receptor and some of the classic pathways, HIF-2 alpha is about as close to DNA as you can get when it comes to blocking some of these pathways that lead to synthesis of VEGF. And so it makes sense that belzutifan would work in this context, and the data looks quite good, safety looks good, but again, it has to be vetted in phase 3 clinical trials. Now, looking forward to other trials that may potentially be practice-changing is COSMIC-313. This really goes beyond what we discussed in my previous talk about doublets and goes on to triplets. If we have PD-1 and CTLA-4 blockade, why not toss on VEGF blockade? And this is a very thorough assessment of that principle. We'll have to see how it works. And then Kathy and I really have our hands full at City of Hope with a number of trials that are looking at CAR T-cell therapies for kidney cancer. And this is really exciting. I mean, we've seen this pan out in a big way for some of the CD19-based cancers like lymphoma. It still remains to be seen whether or not this is going to work in a big way in kidney cancer. But nonetheless, our center and many others are very involved in terms of these clinical trials. And that's a segue to my last slide, which is, it's so important to really think about clinical trials for your patients across the spectrum of diseases, first line, second line, third line therapy. Kathy and I have treatment options for all of those in the form of clinical trials. And Laura, I know you do too at the Cleveland Clinic. It's an outstanding trial center. I think the question that often comes up is a trial right for me? I think that there's some really fantastic resources. kccure.org is one of them. kidneycancer.org is another. And so vital that we get patients onto some of these first and second line studies because they may turn into tomorrow's standards of care. Laura, thanks a lot.
No, and I think you bring up some excellent points, Monty, about clinical trials because nurses and advanced practice providers have the opportunity to encourage patients to explore the options for clinical trials because sometimes those conversations may happen in the infusion area. So we need to make sure that our infusion nurses are familiar with those. And it's not only the clinical trials that lead to drug approvals or not, but it's also ones like you did with the dosing of lenvatinib. You take an FDA-approved regimen and you really try to provide an evidence-based answer. Do we need to use the higher dose, or can kindness and a more tolerable regimen lead to equal efficacy? And your study demonstrated no, it doesn't, which tells us as nurses we really need to hone in on patient education, triage, side effect management, because dose matters. And it's nice to have the evidence to be able to say, let's look at a treatment break. We really want to keep you at this same dose. And if you can, you can. And if you can't, you can't. Then you have to move on and look at other options. We've got a question from the audience. And actually, I'll pose this to either you or Kathy or Monty as far as resources that are available to help patients with these various discussions, be it clinical trials, reimbursement. What are some of the resources, Monty, that you use? And then we can have Kathy jump in.
Yeah, thanks, Laura. I actually really like those two websites that we showcased in the previous slide, kccure.org and kidneycancer.org. I do find that a lot of my patients utilize a tool called Smart Patients, where they have some really great independent dialogues, can chat with patients who are having current experiences on clinical trials. I do really encourage an open dialogue about those conversations when the patients arrive in clinic, because I think certainly we can either reinforce or dispel some of the issues that come up in some of those forums. But there's so many different and fantastic avenues for patients to get information nowadays. I encourage folks to utilize as many channels as they can.
Yeah, Kathy?
Monty, I think that was a very optimistic answer, and that's the kind of person that you are, which I appreciate very much. I think patients sometimes will come in and be completely overwhelmed, right, with going down that rabbit hole of looking at things and looking at websites that aren't recommended. Just as with nursing education and patient education, we sort of guide people to certain information. I think it would be much appreciated if we could recommend these websites to patients and help provide them with some reliable resources.
Yeah, no, that's very important. And, you both and I are blessed to have social workers and dietitians at our institutions. I think we need to be sensitive to the community practices because they don't necessarily have those resources. So if we can identify web-based resources, then we can provide that information to support them. So thank you both for the expertise that you've shared this morning as far as the options for treatment and the resources that are available for us to help our patients. And I think whether you're a bedside nurse, an infusion nurse, an advanced practice provider, oncology nurses' roles in kidney cancer, we bring a lot to the table. And allowing us the opportunity, as Monty, Kathy, we've both talked about, understanding the mechanism of action of these therapies, being able to provide supportive care for the patients, be it nutrition, social work, education. Palliative medicine is critically important as well. And Kathy, you did a great job at really showing the vigilance and the importance of education on both the TKI and the immune-related adverse events and what our options are for treatment modification in order to enhance patient outcomes. So thank you both very much for that. As far as patient and professional communication, we need to educate patients and their caregivers. We need to identify where they are in their understanding. They can be very overwhelmed. They can be very knowledgeable. You've got your frontline patient, your refractory patient. We need to emphasize that immunotherapy works differently than the treatment that would be used in other diseases, including chemotherapy or our targeted therapies, let alone our combinations. And then it's important for us to document what we have done with the education and encourage our patients to document home blood pressure readings, call us when it's appropriate, and document side effects and what they've done on their own. We want to encourage patients to be independent, but at the same point to be able to provide us as clinicians the education we need and the information we need to help manage their side effects more effectively. So in summary, thanks again for joining us this morning. It's really amazing for the three of us to have the opportunity to share about the new approaches, both in the frontline setting, which offers some really positive alternatives to what we've had available in the past, as well as those opportunities now available in the refractory setting, which include both our immunotherapy and combinations and novel therapies. I think one of the key take-home points from my perspective is that we have a number of therapies available and it shouldn't be frontline and done. Second line, third line, treatment for refractory disease is critically important. And we need to have those conversations with our patient and then in the role of shared decision making, allow us to come to a mutual agreement on the most appropriate treatment plan. And nursing professionals are really in a critical role to be able to support patients and caregivers and really be the liaison with our physician collaborators to help with making the most appropriate decisions, both at the initiation of a treatment, when it comes time for dose modification, and at the time of treatment discontinuation, for whatever reason that may be. So thank you both so very much. I really want to thank my colleagues, Monty and Kathy, for joining me this morning on this discussion. Really appreciate it. It's really an amazing time in kidney cancer. We hope this has been helpful to you, our audience. Thank you again, Monty, Kathy. Thank you so much for joining me today.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RYZ860. This activity is supported by educational grants from Aveo Pharmaceuticals, Bristol Myers Squibb, Eisai Incorporated, Exelixis Incorporated, and Merck & Company Incorporated.